Thank you very much. So, a bit of a reminder and then a bit of an update. So, a severe, a non-specific start, severe paroxysms of cough, and it could lead to complications including pneumonia, and was called the 100-day cough. It lasted for a long time. So that was the typical story that many people would have been familiar with, and we see, still see, but not as often. In a neonate or young infant, an unimmunised infant, the story is somewhat different, and essentially the illness can look like many other respiratory illnesses, with simply a cough and a coryza until the moment the baby stops breathing, has apneas and needs intensive care, or a severe respiratory illness needing, with progression, a little bit like a bronchiolitis, eventually needing intensive care. And there's a very significant mortality to unimmunised infants who have pertussis infection. The last case we had here in Oxford was about 2012 and involved a child who died on the intensive care. And there's some interesting immunology behind it, and these little infants get enormously high white counts, and some evidence that removing the white cells during intensive care through plasmapheresis or through exchange transfusion might help. But a severe infection that presents like any other illness, essentially, until they're severely unwell in unimmunised infants. The group I haven't yet mentioned are older children and adults who are immunised, but the immunity's waned. And the typical story there might simply be a cough and a cold, and then a cough that lasts for 2 or 3 weeks, and isn't ever recognised as pertussis because they don't have the whoop, they don't have the post-tussive vomiting necessarily. But studies increasingly show in many areas of the world, particularly where acellular pertussis and also whole cell is used, that adults who are coughing with a prolonged illness, a significant proportion have pertussis isolated. And I can't remember the date or the exact details of the study, but in Oxfordshire, certainly in a study within the last 20 years, adults who had a cough for more than 2 or 3 weeks, something like 20% had pertussis isolated. So it's a severe disease that in young infants and older immunised individuals, it can be atypical and look like any other respiratory infection. So how do we diagnose it? Well, clinically, it may look like that first child, very typical paroxysms of cough. If we catch it early enough, we may either be able to culture or identify the DNA from the organism, and that's the PCR method for amplifying the DNA. And in the first 2 weeks of illness or before treatment, you have a reasonable probability of picking that up, and PCR is more sensitive than DNA. But beyond that, it's antibodies. It's looking at either responses to pertussis in the blood or oral fluid. So Public Health England's understand that you can send them oral fluid from individuals who've had a cough for more than 2 weeks, and they will look at antibodies. Clinical's not a particularly sensitive method. Lots of people have atypical disease, and by the time it becomes typical, it's quite late. DNA becomes negative after a couple of weeks or treatment, and measuring antibodies is difficult in a population who already got an immunity from vaccines or partial immunity, trying to tease out what is a pertussis infection from what's just past infection, and there are ways to do it. But the point I'm making is that diagnostic techniques aren't perfect, they're imperfectly applied, and it's certainly possible to underestimate the number of people in a population with disease, particularly where it's atypical and people aren't looking for it. And the harder you look, usually the more you'll find. So can it be treated? Well, yes, we can give them erythromycin or clarithromycin or azithromycin, one of the macrolides, and if you're intolerant of that, something like Septrin, so there are other drugs. But essentially, treatment's only effective if you give it within the first 7 to 14 days. And after that, it's not going to modify the illness very much. And even before that, it may not modify it greatly. And if you think, again, that many people are identified late or it's not clear early on, then treatment clearly has its limitations. So yes, it can be treated with reasonably straightforward drugs, but that's not going to be the answer. And you may well have had transmissions before you actually diagnose it and treat it. Even giving antibiotics to a severely unwell neonate or unimmunised under 2-month-old on intensive care as well is not going to modify the course of the illness necessarily, and that's why the mortality in these children can be so high. So can it be prevented? That's why we're all here. The bacteria was first discovered by, I think they were French scientists in the early 20th century. One of them was called Bordet, which I think is where the name Bordetella pertussis comes from. And from the early days, people were trying to inactivate the whole cell, the whole bacteria, and make a preparation that was safe and protective when injected into children. It took a number of decades to refine the technique sufficient to have a bacteria that you could inactivate with formalin and give as an injection and would provide protection, and it was quite difficult to ascertain which strains were going to be protective. But this graph from the Green Book shows the introduction of routine immunisation in England and Wales, and shows in the green line the peaks of disease every 3 to 4 years, and the really significant impact that routine infant immunisation with whole cell pertussis vaccines had. The whole cell pertussis vaccine is the entire bug. It's got hundreds of proteins in. We don't quite know which ones are the ones most responsible for the fall in disease, but it worked well. You can see there's a slight blip up in the 1970s where the other feature of whole cell pertussis vaccines became to the fore. They clearly aren't perfect vaccines. They caused a lot of crying and irritability in the children given to them. They gave sore arms, red arms. Occasionally, they certainly caused a significant amount of fever. And because of a concern about the possible rare severe adverse events in the 1970s, there was a scare. I was going to say we've been there before, but we were going to be there in about 20 years with MMR. There was a scare about it. Coverage fell, which is what that black line shows. And there was a significant resurgence of disease with deaths in infants. I'm not going to labour the story very much, but a lot of work was put into trying to investigate adverse events and was reassuring, and public confidence rose, vaccine coverage improves, and disease, again, with the whole cell vaccine is controlled well. So whole cell pertussis vaccine continues to be the mainstay of global immunisation against pertussis, and was the UK's routine vaccine until 2004. Because of the sore arms, people wanted to, and irritable babies, people wanted to see if they could improve on the vaccine. So that's where we have a cellular vaccine developed in the 80s and 90s. And the vaccine, instead of taking the whole organism, takes a number of protein components, and those are the names of them: pertussis toxin, pertactin, filamentous hemagglutinin, and fimbria. And if you look at this summary of product characteristics in the acellular pertussis vaccine, different vaccines will have different combinations of these proteins and different quantities. And these were thought to be the key elements to provide good immunity. So acellular pertussis vaccines were developed in the 1980s, 1990s. They gave reasonably good antibody responses. In fact, if you look at antibody responses in relation to whole cell pertussis vaccines, they're often better. So pertussis toxin antibodies are better after acellular than whole cell. And one feature was very clear. They had far less adverse events in terms of local reactions, sore, swollen red arms, crying babies, and fever. And just as an aside, one of the events that had caused a lot of stir around whole cell pertussis vaccines was a thing called hypotonic, hyporesponsive episodes. I don't know if anyone's ever come across them. So a little bit like a faint, when babies get a vaccine, and it can be any vaccine, not just whole cell or acellular, shortly or several hours afterwards, they go pale, floppy, and poorly responsive. Clearly quite a frightening event for a parent, but then recover very rapidly. And these had been still rare, one in several thousand immunisations, but more common with whole cell, and were clearly less common with acellular. So all round, this was felt to be a vaccine that induced good antibodies, and seemed to provide protection from disease, but at a much less, but was much less reactogenic. And so throughout Europe became, and many developed world countries became, the standard vaccine. And from 2004 here and through that period in other countries in Europe, was widely adopted in a variety of schedules. So is pertussis still a problem? We've got a vaccine that provides as good an antibody level as whole cell pertussis vaccine, and is apparently safer in terms of, well, less reactogenic. So these are just data from Public Health England through 2007 to 2016, showing number of confirmed cases, and these are laboratory from confirmed cases, so they're almost certainly a significant underestimate of disease. 2004, the acellular vaccine was introduced, and you can see there was just a handful of cases grumbling along through to 2011. And then in 2012, we had a very significant rise in the number of cases, and a rise that was across all age groups, and was associated with an increase in number of deaths in the neonatal, in the under 2 months, in the unimmunised. And in fact, in the year around that, there were 14 deaths in the unimmunised infants compared to around 10 deaths in the preceding several years. This was across all age groups, but clearly the mortality was in the young infants. And there were a number of theories as to why this could be, and clearly the bug could change, and there are lots of studies looking at the genetics of the bug, and there are possibilities around that, but it doesn't seem to be perhaps the driving force behind this. Coverage of the vaccine remained the same during that period. And one thing that was clear, however, was that it seemed to be a finding replicated in other countries using the acellular vaccine. So something about the acellular pertussis vaccine was not as good as the previous whole cell, and what's become more and more apparent is that acellular pertussis vaccine, while it gives a good antibody response, probably doesn't give us protection for as long. Whole cell pertussis or natural infection was thought to protect you for as much as a decade. The figures are a little bit variable, but acellular pertussis protection wanes probably more rapidly than that. And protection from disease might stay reasonably robust for a little bit longer, but protection from carrying the bug probably wanes more rapidly. And certainly in outbreak studies in Finland in the last 10 or 15 years, children who have been further away from their acellular pertussis vaccine certainly start, contacts of cases in nurseries, certainly you start to pick up carriage of the pertussis in the outbreak, even in children who are asymptomatic, and that's more common the further away you get from having had your immunisation. And that's been confirmed more recently in studies with baboons, who are a good model for human pertussis, that the acellular vaccine and the whole cell will both protect you from infection, but the acellular pertussis vaccine will allow carriage, so that when you're challenged with the organism at a later date, the infant baboon child doesn't get disease, but they certainly carry the organism. And for all these bacteria, carriage is the thing that keeps them circulating in the community. So whilst you might not notice people getting disease, they carry. And the lack of long-lasting immunity and the lack of ability to robustly protect from carriage is probably one of the most significant reasons why we are now seeing disease in the UK and many other countries who have adopted this as their standard. Now, we'll come on to maternal immunisation in a minute, which all of you are very familiar with in terms of delivery. Pertussis, despite maternal immunisation, hasn't gone away. We haven't altered our programme for older children and adults particularly, and so we're still seeing significant numbers of cases, much elevated to previously. And the cycle of epidemics is such that every 3 or 4 years you'll have a peak, and you can see even going to 2016 that disease rates were higher than the year or two before. So pertussis is still a problem, and this isn't just the UK. Just a reminder, and this was nice data from the Green Book, these are infants who've got disease by week of onset of disease, and the grey are the unimmunised, and you can see that throughout the first year of life, the bulk of infants getting disease in the UK at the peak of that epidemic or out there were with the unimmunised under 2 or 3 months. And as soon as you had had 1 and certainly 2 doses, the actual incidence of disease falls away very rapidly. So pertussis is still a problem. So what are we doing about it currently? Well, the JCVI, the body tasked with giving national guidance, had suggested delivering pertussis to all pregnant women from 2012 onwards, and had reiterated that advice in 2014. The idea behind that is not predominantly to protect the mother, but to give the mother sufficient antibody that it's transplatantally transferred to the infant and protects the infant in those critical first 1 or 2 or 3 months of life where all that disease burden falls. So that programme has been implemented and subsequently modified in terms of the vaccine suggested, which is now the 3-component Boostrix, and has shown very good efficacy in preventing disease in early infants. So of the 16 deaths, I think it is, in the last 3 years, around that time period, all of them have either been in infants of unimmunised mothers or mothers immunised too close to the date of delivery to actually give them a significant amount of antibody. There's also been subsequent work from studies in Europe suggesting that the earlier you give the vaccine in pregnancy, the better, and so the recommendation now has dropped to giving it from 16 weeks and certainly 20 weeks onwards where possible. So it's efficacious. It certainly prevents disease in the neonates. One of the concerns about it is that if you give a significant amount of pertussis antibody to an infant through the maternal transmission so that it's there at birth, will you actually alter their response to their own vaccine? So we know that the more antibody you've got to a vaccine, the less likely you are to get a good response if you give a subsequent dose. And studies again have suggested that infants of mothers who've been immunised, whilst being protected from pertussis, certainly have slightly lower responses to their own immunisation. Whether that makes any difference in the long term is uncertain, and they're not dramatic differences, and they still get responses, but it's something that needs to be studied further and kept and reviewed going forward. And certainly the risk of pertussis infection in older age groups is much less in terms of mortality and outcomes than in neonatal, the unimmunised 2 months old. So I think there's no doubt about the balance is that we should be immunising mothers. It's still, uptake is still not complete, and I'm not so familiar with the programmatic aspects of this, but clearly there's a way, significant improvement that could still be made in terms of coverage. But it's an important area for us to understand more about the effect of maternal immunisation on infant responses. So what can we do in the future? Well, it's interesting when you read the WHO guidance, whole cell pertussis is the recommended vaccine, and they specifically recommend that countries who haven't adopted acellular pertussis vaccine continue to use whole cell. We know it maintains good control of disease, the safety profile is well understood, and interestingly, Bill and Melinda Gates Foundation had looked at neonatal or early infant pertussis recently in a whole series of studies, and actually in countries where they're having whole cell pertussis immunisation, the burden of disease in those early months is actually still not particularly excessive. There had been interest in whether maternal immunisation should be more widely used in developing world settings, and from more recent discussions with people who've been involved with those studies, I think they're not completely certain that's going to be a useful thing in countries that are using whole cell pertussis vaccines, because they still have good control of, reasonably good control of disease in those early months. There are other countries where they're using acellular vaccines who've adopted maternal immunisation as a useful strategy. But clearly it's not ideal to be having to constantly deliver a programme of immunisation in mothers. Could we use boosters? Well, I know that Public Health England have modelled the use of boosting pertussis vaccines in adolescents, but I think the evidence is that immunity isn't long-lasting enough, that boosting in adolescents will have a massive impact on neonatal disease, given most people are having children, well, ideally not in adolescence, but in their 20s, 30s and later. So boosters are not clearly the way to solve this problem. Could there be new vaccines? Well, there's a lot of interest in new vaccines, whether you could develop a vaccine that looks like whole cell in terms of its protection, but looks like acellular pertussis vaccine in terms of its reactogenicity, and certainly within the Oxford Vaccine Group and within a wider range of research organisations, people are looking at novel vaccine candidates. And we understand a little bit more about immunity now as to help to design those. And one of the things we're involved with in the vaccine group at the moment is a consortium across Europe called Periscope, Pertussis Correlates of Protection in Europe, where we're trying to understand the immunity to whole cell and acellular vaccines so that, again, we can try and design vaccines that incorporate the good features of both. And interestingly, we're planning to go back and actually look at whole cell vaccine and compare it directly to acellular pertussis vaccine in the coming years. One of the striking things is that even if you've had one dose of whole cell pertussis vaccine in your life, and there's nice data from Australia and the US on this, even if the rest of your immunisation programme is with acellular pertussis vaccine, you're significantly better protected against whooping cough in the future. So there's something very potent about whole cell. We don't know whether it's other antigens, other proteins in the vaccine, whether it's something about the degree to which it stirs up your immune system, and even though it gives you a sort of sore arm. But there's something we need to understand better about what that vaccine did. And as I say, the WHO at the moment would not recommend any country to be starting with acellular vaccines if they hadn't already done so. So despite having, I think Prof Moxon, who led the vaccine group for many years, always said introducing a vaccine is the start of a multi-year experiment in terms of whether it provides protection, whether it's safe. Well, pertussis vaccines have now been in use in the UK since the 1950s, so is that 50 or 60 years? And we are still having a situation where the epidemiology is evolving, and we still need to understand better how to use the vaccines we have. I'll stop there, and thank you.